Hello and welcome everyone. This is a part 2 of acute lymphoblastic leukemia. In this video, we are going to discuss about molecular and genetic abnormalities related to acute lymphoblastic leukemia. Genetic biomarkers are critically important for prognostic prediction and WHO classification of B-cell acute lymphoblastic leukemia. This picture shows the pediatric ALL molecular and genetic abnormality distribution and the distribution of molecular and genetic abnormalities in adult ALL. Let's learn one by one. First is hyperdiploidy. It is seen in 30% of pediatric ALL and 10% of adult ALL. The mutations present are FLT3, NRAS, KRAS and PTNP11 genes. There are two types of hyperdiploidy. First, understand what is hyperdiploidy. When the chromosomal numbers are increased more than 46, then it is called the hyperdiploid. The normal number of chromosome is 46. So, in high hyperdiploidy, the chromosome is between 51 to 65 and DNA index is more than 1.16. In low hyperdiploidy, the chromosomal numbers are decreased but less than high hyperdiploidy. It is between 47 to 50 chromosomes and DNA index is between 1 to 1.16. The chromosome gained in high hyperdiploidy are 4, 6, 8, 10, 14, 17, 18, 21 and X. The high hyperdiploidy has a favorable prognosis. The chromosome gained in low hyperdiploidy are X, 21, 14. It has unfavorable prognosis. The second is hypodiploidy. Hypodiploidy means the loss of chromosome. So when the chromosomal numbers are less than or equal to 44, it is called hypodiploidy. There are mainly three types: high hypodiploid, low hypodiploid and near haploid. Near haploid means around only half of chromosomes are present. So what is the half of 46? It is 23. So around 23 chromosomes are present, then it is called the near haploid. The high hypodiploid has a 40 to 44 chromosomes, low hypodiploid has a 30 to 39 chromosomes and near haploid has a 24 to 29 chromosomes. This all has a poor prognosis. The low hypodiploid has a deletion of IKZF2 and TP53 mutations. The near haploid has a IKZF3 and RAS mutations. Third is IAMP21, that is intrachromosomal amplification of chromosome number 21. It is seen in 2% of pediatric ALL and 11% of adult ALL. Older children and adolescents are seen with common or pre-B immunophenotype. It has a worse prognosis, it has a low WBC count and some secondary abnormalities are also seen with IAMP21. They are gain of chromosomes X, 10 or 14, monosomy 7 or deletion of 7q, deletion of 11q including the ATM and KMT2A genes, as well as abnormality affecting IKZF1, CDKN2A, PAX5, ETV6 and RB1 alteration. Fourth is BCR-ABL1, which is also called Philadelphia chromosome, translocation 922. It is seen in 3% of pediatric ALL, 25% of adult ALL. IKZF1 and CDKN2A alterations are commonly found. The alteration of B lineage transcription factor genes, particularly IKZF1, are the hallmark of Philadelphia ALL or BCR-ABL1 ALL. And it is a key determinant of lymphoid lineage and it is responsible for resistance to therapy. It is associated with unfavorable outcome. The prognosis has been now improved with combined chemotherapy and tyrosine kinase inhibition. The CD25 expression is found on immunophenotype of this type of ALL. Fifth is BCR-ABL1-like ALL. The main abnormality is gene fusion. It is seen in 50% of pediatric ALL and 40% of adult ALL. The deletions are observed in IKZF1, PAX5, AVF1, TCF3 and VPREB1. It has a poor response to treatment because it causes resistance to L-asparaginase and daunorubicin, and it also has a high risk of relapse. The expression of CRLF2 gene product, which can be assessed through flow cytometry, which can serve as a screening test for CRLF2 gene rearrangement, and it is the hallmark of identification of PH-like BLL. Sixth is KMT2A rearrangement. KMT2A, also known as MLL gene. It is present on 11q23. It is present in 10% of ALL and 5% of AML. More than 80 genes that can form the chromosomal translocation with MLL gene in leukemia. Most common genes translocations are AF1, formerly known as AF4, AF9 and ENL. These three are most common. 50% of patients diagnosed with pro-BALL aged 6 months or less harbor this translocation 411 KMT2A AFF1 chromosomal rearrangement. The frequency decreases in older infants 10 to 20% and drops to 2% in children. It has an unfavorable prognosis. The immunophenotypic markers are following. The CD10 is negative, CD34 is positive. B lymphoid markers such as CD19, 22, 79, 8 TDT are positive. Myeloid markers CD15 and CD65 are positive. The component of leukocyte antigen complex, which is HLA-DR, it is positive. Other negative markers are CD24, IgM, CD13, CD33. Seventh is ETV6 RUNX1, translocation 1221. This translocation involves the fusion of two transcription factors essential for hematopoiesis, that is ETV6 RUNX1. It is seen in 25% of pediatric pre-BALL. It has an excellent prognosis and CD10 is positive on immunophenotype. Eighth is ETV6 RUNX1-like translocation. It has a similar gene expression and immunophenotype profile with ETV6 RUNX1 fusion BALL but lacks the fusion gene. It is seen in 3% of pediatric BALL. In immunophenotype, there is a CD27 positivity and CD44 low or negative. The ninth is TCF3 PBX1. It is a translocation 119. It is seen in 25% of pediatric pre-BALL. More frequent central nervous system relapse are observed with this molecular typing. The prognosis is inferior. In immunophenotype, CD10, CD19, CD34 positivity is seen. 10th is TCF3-HLF. It is a translocation 1790. It is seen in less than 1% of pediatric cases. It has a poor prognosis. 11th is IGH-IL3. It is translocation 514. It is seen in less than 1% of cases. It is aggressive subtype with poor outcome. Now the last category is others. First is CDKN2A deletions. The location is 9p21.3. The abnormality can be deletion or hypermethylation. It is seen in 5 to 35% of children and 30 to 45% of adults with BALL. It has a poor prognosis. Second is CRLF2 deregulation rearrangement. The location is XP22.33 and YP11.2. The abnormality includes gene fusion or point mutation. It is seen in 5% of pediatric BALL, 5% of adult BALL, 50% of Down syndrome associated BALL and 50% of PH-like, Philadelphia-like BALL cases. It has a poor prognosis. Translocation of DUX4, DUX4 encoding the double homeobox transcription factor 2 immunoglobulin heavy chain locus gene, IGH gene. The abnormality is gene fusion or rearrangement. It is seen in 5 to 10% of BALL. Particular immunophenotype is important. This type of BALL shows CD2 positivity and CD371 positivity. Even if the deletion of IKZF1 is present along with this case, the outcome is good. So the prognosis is excellent. And the CD371 expression is a pathognomic feature of this leukemia. Next is ZNF384 rearrangement. The abnormality is gene fusion. It may manifest as a 6% of childhood BLL and in 48% of childhood B myeloid mixed phenotypic acute leukemia. It has an intermediate prognosis and depends on the fusion partner gene. MEF2D rearrangement. The abnormality is gene fusion or rearrangement. It has a distinct immunophenotype which has a CD10 negativity and CD38 positivity. It is seen in older age, around 14 to 15 years, and it has a poor prognosis. NUTM1, which is nuclear protein in testis midline carcinoma family 1. The abnormality is rearrangement or gene fusion. It is seen in 1 to 2% of childhood BLL. It has an excellent prognosis. PAX5 altered. Abnormality is gene fusion, deletion or amplification. It is seen in 10% of childhood BLL. PAX5 PATR. The universal PATR mutation and deletion or mutation of remaining allele, mutation in RAS and JAK2 signaling genes and hotspot mutations, this all are seen in this type of BLL. It is seen in 2% of childhood BLL. It has an intermediate to favorable prognosis. A single heterozygous mutation in IKZF1, which is also called N159Y. IKZF1 nuclear mislocalization. The abnormalities can be deletion, point mutation or gene fusion. It is seen in less than 1% of cases. Various studies have found that IKZF1 aberrations to have a negative prognostic impact, manifesting as a resistance to TKI therapy, high level of MRD, poor survival and increased frequency of relapse. This is all about molecular and genetic abnormalities related to BALL. Now we see in short about good prognosis and worse prognosis. The first category is a patient and clinical characteristics. If the age at diagnosis is 1 to less than 10 years, if gender is female, if race is Caucasian or Asian, patient has a no Down syndrome or no testicular involvement, and WBC count as diagnosis are less than 50,000 per microliter, and if immunophenotype is BLL, this all represent the better prognosis. If the age is less than 1 year or more than 10 years, if the gender is male, race is African American Hispanic, if the Down syndrome and testicular involvement are present, if WBC count as at diagnosis are more than 50,000 per microliter, and CNS involvement is present at a diagnosis with traumatic tap with blasts, and immunophenotype is TLL, then this all represent the worse prognosis. Now let's come to the cytogenetics and molecular. Three groups have an excellent prognosis. First is high hyperdiploidy, ETV6 RUNX1 and NUMT1 rearrangement. The certain cytogenetics and molecular have a worse prognosis, and they are hypodiploidy, KMT2A rearrangement, BCR-ABL1, BCR-ABL1-like ALL, TCF3HLF, MEF2D rearrangement, intrachromosomal amplification of chromosome 21, BCL2 and MYC rearrangement. These all represent the worst prognosis. And lastly, minimal residual disease. If it is negative and continuously decreasing or becoming negative, then it shows the better prognosis. And if it is positive and increasing or persistently positive while monitoring, it shows the worst prognosis. This chart shows the percentage of different molecular and genetic abnormalities according to the age of the patient. So these are the references for this video. Hope you like it. Thank you. Bye. See you in the next video.